Okay. Assalamu alaikum. Assalamu alaikum. Thank you very much for giving me the opportunity to discuss this interesting topic. So let's start with the pool. Who thinks that obstructive uropathy is an autoimmune problem? Can you raise your arm? Raise your hands. Okay. And who thinks it's a mechanical problem? Can you raise your hands? Okay. And who thinks it's both? Can you raise your both hands? Okay, thank you. Fine. So this is the theme of my presentation, and you can see that whatever you see on the surface is not always true. Diseases can behave differently, and we need to dig a little more. So this is the introduction of my. Now, if you see this slide, you can find that common causes are always common, but there are uncommon causes as well. For example, in case of obstructive uropathy, what we are discussing here is autoimmune problem related obstructive uropathy can be caused by IgG4 related diseases, lupus, GPA, sarcoidosis, and Sjogren's syndrome. So let's start with the case presentation. So 65 years old male presented with dysuria and flank pains, and on examination there is abdominal tenderness and elevated renal functions, anemia, and mild proteinuria. MSU is negative. Ultrasound showed mild to moderate bilateral hydronephrosis. So what's the next investigation would you like to do? Anybody? We have already ruled out infection. Sorry. Okay, the CT scan was done. Can anybody tell any findings here? On the CT scan A. So you can see a mass encasing the aorta and iliac vessels, and you can see a large kidneys here. On the B, it's a normal CT scan with a normal pancreas. So this patient was diagnosed with the idiopathic retroperitoneal fibrosis, was treated with the steroids for the period of 6 months, and gradually steroids were reduced and stopped. And after 1.5 years, in a follow-up, he had another CT scan. What do you see here? Anybody? Okay, fine. So you can see the mass has been reduced in size significantly here in A, and hydronephrosis improved. However, in this picture, you can see the pancreas, sausage-shaped type pancreas, edematous, enlarged. So what other investigation you would like to do here? Any comments on it? Yes, you are right, absolutely right. So we did the amylase, lipase, which was mildly raised, ANA, ENA was negative, and IgG4 level were raised. So the diagnosis of IgG4 related retroperitoneal fibrosis with autoimmune pancreatitis complicated with obstructive uropathy was made. Patient was treated again with the steroids, and it made a remarkable improvement. So what is IgG4 related diseases? IgG4 related disease is a systemic fibroinflammatory disorder characterized by IgG4 positive plasma cell infiltration, fibrosis, and elevated serum IgG4 level. This disease can affect any organ of the body. So it's a systemic disease, it can affect one organ or can affect multiple organs at a time. And in this disease, there will be the development of the mass around the organ, and it will cause the pressure effects on the organ or can increase the size of the organ. So that's why sometimes it's very difficult to differentiate between the malignancies, infections, and the IgG for related retroperitoneal fibrosis. So let's discuss a little bit of history, and it's a journey from retroperitoneal fibrosis to IgG for related retroperitoneal fibrosis. So in early 1900s, this disease was thought to be idiopathic, and Albaran was the first who observed the ureteric obstruction because of the retroperitoneal fibrosis. Fast forward to 1948, Ormond's disease, named at the name of John Ormond, who first identified and described it as the idiopathic retroperitoneal fibrosis. Between 1950 and 1990s, doctors, they identified an interesting immune connection. Some of the cases with the retroperitoneal fibrosis, they responded very well with the steroids. So there was a question whether it's an immune-related disease. So in 2001, some of the researchers who were studying autoimmune pancreatitis, they made a remarkable discovery. They found that IgG4 positive plasma cells actually causing the fibrosis. So that raised another question whether retroperitoneal fibrosis is also associated with or also driven by the IgG4 related plasma cells, which was confirmed in 2006, and by 2011, IgG4 related disease officially classified as systemic immune disorder. And in 2017, multiple studies confirmed that about 30 to 60% of the patients, they are with the retroperitoneal fibrosis, they are actually IgG4 related. So that remarkably changed our understanding about the fibrotic disease, because previously we used to put the stents and other things to relieve the obstruction. Now we knew that this disease is steroid responsive, and we can use the immune suppression rather than to do the unnecessary surgeries. So about epidemiology, in 2023 studies found, in the studies we found the overall incidence of retroperitoneal fibrosis was between 0.78 to 1.38 per 100,000 people. Male affected more than female, and interestingly, there is a geographically variation in the prevalence. So it's higher in Japan as compared to other countries. So I don't know why this slide is like that. Okay, fine. So the frequency of retroperitoneal fibrosis in IgG4 related diseases. This table summarizes the data from multiple studies, especially in the patient of autoimmune pancreatitis. The frequency of IgG4 related retroperitoneal fibrosis was between 3 to 15%, and overall frequency of retroperitoneal fibrosis in IgG4 related disease was 9.9%. Fine. So etiology, ये इस तरह क्यों आ रहा है सारा? एक्चुअली प्रेजेंटेशन इस तरह तो नहीं थी. अच्छा, ठीक है. So as I already said that 30 to 60% of the cases are IgG4 related in case of idiopathic retroperitoneal fibrosis. The secondary causes can be drugs, malignant diseases like lymphomas, and it can be caused by the radiotherapy and surgery, etc. So a little bit about the pathogenesis. The trigger can be infection, can be environmental factors, or molecular mimicries will affect on a genetically susceptible individual like HLA-DR-B1 or CTLA-4 mutation individuals. It will stimulate the abnormal immune system which will activate the B cells and IgG4 class switching, which will produce the plasma cells. And it will also cause the stimulation to T helper cells and T regulatory cells, which will further cause the cytokine activation and causing the inflammation, and later T regulatory cells will produce the collagen and cause the fibrosis. And like that, it will cause obstruction of the ureters or neighboring organs. Now, it's very important to understand the subtypes of IgG4 related diseases, because the management will differ between two. So there is a proliferative subtype and there is a fibrotic subtype. So fibrotic subtype will have dense lymphoplasmacytic infiltrate, there will be more inflammation, and it is responsive to steroids. However, in comparison to that, fibrotic subtype, it's less responsive, lacks plasma cells, and poor response to steroids. So now have a look on this slide. On the left top corner, you can see the lymphoplasmacytic infiltrate. And here it is the immunohistochemistry slide. And you can see these brown IgG4 stained plasma cells, and IgG4 to IgG ratio should be more than 40 to say it's strongly say that it is a IgG4 related disease. And this is the fibrotic area. It's a classical woven mat type fibrosis, which is known as storiform fibrosis. Storiform came from the term storia, which means woven mat or cartwheel type fibrosis. If you look at this slide, you can see that there is obliterative phlebitis. Veins are obstructed by the plasma cells. This, you will see this in more chronic phase, like a fibrotic phase. So the clinical presentation is often asymptomatic. You will find diagnose these type of cases when you do the CT scan or MRI scans. However, presentation can be like a flank pain, lower abdominal pain, or back pain. Fever is very uncommon. So if you are suspecting IgG4 related retroperitoneal fibrosis and patient presents with the fever, then it's very, very important to rule out malignancies or lymphomas or infections. So how we'll diagnose? So we'll do the serum IgG4 levels. It will be raised in proliferative subtype. However, it can be normal it's normally normal in the fibrotic subtype. But it's important to note that IgG4 related, serum IgG4 level can be raised in lymphomas and like Castleman disease and also in autoimmune pancreatitis. So we need to do a CT scan or MRI scan to diagnose it. In MRI scan or CT scan, you'll see that a mass formation will be encasing the aorta or iliac vessels or ureters. So it's a typical location. So if you find the typical location of the mass, then you can somehow treat the patient without doing a biopsy. Even though the histopathology or biopsy is a gold standard, but sometimes radiologists are understandably reluctant to do the biopsies because of the location of the mass. So that means that if the location is typical like this, you can see this mass enclosing the aorta, and you can see the mass is a typical location of IgG4 related retroperitoneal fibrosis. However, I will be very worried about this type of mass. It's irregular margins and location is not very typical. So I would definitely do the biopsy first to differentiate it from the malignancies or infection. And it's also important that we should take a proper chunk of biopsy. You will take the biopsy from the peritumoral region. It can be similar to like IgG4 related disease, and then we can wrongly treat the patient. So this is a differential diagnosis we have already discussed, and especially in Pakistan, we need to always rule out tuberculosis. So the first line management will be corticosteroids, 40 milligram methylprednisolone, which we will taper down gradually, and we will expect the response within 4 weeks. However, if somebody got the stent put in, I will remove the stent like in 2 to 3 months' time on the safe side. And there are steroid-sparing medicine will be mycophenolate, Moftel, azathioprine, and methotrexate. For relapse or even for the fibrotic disease, the rituximab has a very good results. A study was performed in the patient with the fibrotic subtype, 19 patients treated with the rituximab and no steroids. All 19 had symptomatic improvement. 40% of the patients with ureteral stents had successful stent removal. We have surgical options like put the stents in a severe cases, and where it's difficult to put the stent in, then we can do the nephrostomies. And interestingly, with the treatment, you will see that we will be able to remove the stents and nephrostomy, reverse back the nephrostomies. Now the second case. This case is about 30 years old female with dysuria and GI upset and flank pain. On examination, there is mild abdominal tenderness, anemia, elevated inflammatory markers, high creatinine, low complements, and urine analysis show proteinuria and hematuria, and patient is known to have lupus nephritis. Ultrasound scan done, which showed hydronephrosis and thickened bladder walls. So a CT scan done, what do you see in the CT scan, anybody? So you can see this reduced bladder capacity and thickness of the bladder wall, this one. And this CT will show you the hydronephrosis, and you can see that this intestine with the thickened intestinal wall. So what's the next step of management? What do you think? What should we do? Do we treat the patient with immune suppressions, or do we do something else? We'll investigate, yes. So even though we have already done the MSU and ruled out some infection, but in countries like Pakistan, we'll definitely do urine culture for Mycobacterium tuberculosis, which was negative, gene expert, negative. So we have ruled out, because if we'll treat the patient with the tuberculosis, obviously it will just worse the things. And then cystoscopy and biopsy, and you will find the chronic inflammatory infiltrate in subepithelium. Oh. So this is the case of obstructive uropathy secondary to the lupus cystitis. So lupus cystitis is a rare but serious manifestation of SLE. It's immune complex mediated bladder inflammation leading to fibrosis and uterine obstruction. So you'll see these type of cases, especially in patients who got like a severe uncontrolled SLE, and people will present, and interestingly, lupus nephritis coexist sometime with the lupus enteritis. Pathophysiology is not clearly understood, but the studies showed the deposition of immune complexes, immunoglobulins, complements, and it will basically mediate the vasculitis on the bladder wall, cause the arteriolar damage. And it has been noticed that there is an increase of IL-8 and chemokines and also anti-intermediate filament antibodies on the bladder wall are also seen. And interestingly, with the treatment, the level of these antibodies gone down, though there is no clear relationship with that. However, that's what the studies has noticed, and the further research is required. So these are the risk factors, and you can see that patient with the lupus nephritis and enteritis, you see in clearly in the active disease and uncontrolled disease like raised dsDNA, low complement, high SLEDAI count score. So it's very important to control the disease early. Diagnosis on the basis of, obviously, do the blood like complements, see the disease activity, and urine analysis to rule out infection, abdominopelvic CT scan to differentiate from the other causes of obstructive uropathies, and then cystoscopy and biopsy. Oh, sorry. So this is data from multiple studies that how they treated. So mainstay treatment remained the high-dose corticosteroid, and depending upon the complexity of the cases, combined with the mycophenolate and cyclophosphamide. And the symptoms range from abdominal pain to vomiting, diarrhea, and dysuria, especially because the enteritis coexists with this lupus cystitis most of the time. And if not treated properly, then patient can get intestinal pseudoobstruction, hydronephrosis, mesenteric vasculitis. So it's very, very important to recognize such cases in the early stage. So this bit of the treatment I've already told you. If in case of refractory cases, we can add belimumab, tacrolimus, and in some cases, intravesical dimethyl sulfoxide has also been used. So now we have already discussed about the lupus cystitis because of the lack of time. I'll just quickly go through other rare causes like GPA, sarcoidosis, and Sjogren's syndrome. So as we all know that GPA is a medium to small vessel vasculitis. It will cause the vasculitis in the bladder wall, can cause the stricture, and obviously later cause the obstruction. And if we do the histology, we'll find the granulomatous vasculitis there, and the treatment will be high-dose steroids, rituximab, or cyclophosphamide induction as we treat the GPA in normal cases. Sarcoidosis is a non-causating granuloma causing strictures. So it affects in different ways. It can cause the stricture, it can cause the granuloma formation in the retroperitoneum, and will behave similar to IgG4 related diseases, but how we differentiate it from the IgG4 related diseases, that it will cause a non-causating granuloma, or there will be no storiform fibrosis or IgG4 positive plasma cell. The treatment will be corticosteroid, immune suppressant like methotrexate, and azathioprine. And another way how sarcoidosis can affect is it will cause a hypercalcemia and stone formation. In that way, it will cause the obstruction. Sjogren's syndrome, as we all know that it is a disease of the exocrine gland, but however, it will have the extraglandular presentation. It can cause the renal tubular acidosis and then cause the nephrocalcinosis, and in that way, it can cause the obstruction, and also cause the vasculitis, inflammation in the bladder wall, and like that it can cause obstruction. So in the biopsy, you will find the chronic lymphocytic infiltrates. Again, treatment will be steroids, immunosuppressant, and if sometime requires stuntings. Okay. So the take-home message is that yes, common causes are always common, but there are always uncommon causes of the disease. When we don't find the answer, we need to dig more. And diseases like IgG4 related diseases, previously we was quite afraid of fibrosis. We don't need to be afraid anymore, because we know that there is a treatment. Even in the fibrotic stage, we can treat the patient and make the patient better. Thank you. Any questions?